Thank you, Sarah Jane, and thank you for joining us. So, Yinlin and I will just have a conversation, but if you have any questions, please feel free to stop us as we go along. If we don't see hands, we'll assume we can carry on and we can wait for questions at the end. So thank you, Yinling, for joining
Thank
me.
you for having me.
So as an OBGYN, in your work, diagnostics play a critical role, right? And for women, for different conditions and for different ages. But why is it that women in low-middle income countries have such difficulty in accessing diagnostics?
I think it's very important that the crowd here focuses a lot on the technical aspects of how we can create point of care tests, diagnostics that are available, but we need to see where the women are and how do we access them rather than how they access us in terms of healthcare. So if your diagnostic requires that a woman comes into clinic, have the test and return to the clinic in 3 days' time, you can nearly expect 70% of them will never return back to the clinic. That is just a fact in lower middle income country. So diagnostics for women, when we talk about healthcare, we talk about education, poverty, the economic aspects, we really need to go to the women and see how do diagnostics access these women, because they're not going to come out to you. And when you talk about obs and gynae, you're looking at a life course. Do we realize the number, proportions of children, childhood and teenage pregnancies? Do they understand what sexually transmitted disease is? They don't understand that. Then we move on to anemia in pregnancy. It's a simple test. Do they then think being tired is part and parcel of pregnancy? So things, simple finger prick tests of checking hemoglobin, thalassemia, all that are important tests for women during parts of their reproductive life. Looking at all these diagnostics for ultrasound, simple imaging. Can we make it accessible to women? So lots of opportunities to address equity in diagnostics for women in their reproductive age.
And it's interesting you mentioned pregnancy testing as the example, because pregnancy testing is the entry point to multiple interventions for women, yet pregnancy testing is not as accessible. And for a young girl, the first time you learn that you're pregnant is with a health worker, so there's a power dynamic at play. So it's a segueing into self-testing, because pregnancy testing is one example of self-testing. So the work you do with the Rose Foundation is more about improving access to self-testing and self-collection for women with for HPV screening. And we keep saying self-testing empowers women, it gives them efficacy, self-efficacy, it gets them to be more involved in their own health care. Has that been your experience with the Rose Foundation? Does it actually do that?
Yeah. So let's take a step back. In the work of how we developed Program Rose, which I'll explain to everyone in a short while, is understanding that healthcare in its infrastructure now with clinics and tertiary hospitals are really not places where the underserved would want to access. I was sharing with Angela yesterday, for many people, stepping into that setup would mean loss of income and losing someone dear. Death, it's associated with death. Why would I walk into a facility, healthcare facility, when I'm well, to have a screening test that would cost me money, and then to be told that potentially something is wrong with me? So how do we make screening tests simple, accessible, and not threatening? I'm a gynae oncologist, so many patients, before they even reach the hospital, they get the nausea and vomiting because of their experience and association with what interventions mean in hospitals. So what Program Rose is not just a test, it is a HPV self-sampling method that can be done in the community whereby women with a positive screening test are then linked to follow up if they need to. So the program was established in around 2018. It was very difficult to explain to women about swabs, about PCR, but now women even understand what CT values are because of COVID, which has made it simpler for us to explain that. So back in 2017, 2018, when we developed this self-screening program, it came at a point where HPV testing has superseded Pap smears as the main cervical screening test of choice. So women now no longer need a Pap smear every 3 years. They need as few as 2 HPV tests, 2 HPV PCR tests in their lifetime. And that is with the goal of eliminating a cancer in our lifetime. So for those of you who are not familiar, cervical cancer is the first cancer that we can potentially eliminate in your lifetime and my lifetime. Think about that. So with vaccines and effective screening tests, we can do that. But screening in itself doesn't save lives. It is the linkage to care. So what we have built with Program Rose is going to the community to screen women in an area where they're comfortable with, teaching them how to do a low vaginal swab. And this swab will then be run on PCR to have a HPV, high-risk HPV detected. And the results will then be communicated to them by WhatsApp on their mobile phones. Now, they already know what's to come after they give us the swab. So unless they have a positive test result, these women would never need to step into a healthcare facility and burden an already stretched healthcare facility. So Rose Foundation then is a foundation that runs Program Rose, working with community leaders, working with local champions, may it be the local mayor or NGOs, as long as there's a trusting relationship between an individual with the women around them. That's where Rose will go to screen the women who are eligible for cervical screening. And most of them would not have had a Pap smear in their lives.
Still pausing to see whether a question. Sure.
I'm not sure if I need the mic. I'm pretty loud. But one thing, when I have talked to people about self-sample collection, the question is, well, how do you know that they're going to be able to do it? So I'm just curious, how do you address that question? What has been your experience in terms of the yield and whether or not that is really an obstacle, which I'm guessing is not, but I'd love to hear some of the ways you address that.
So I think we had a learning curve in terms of educating women how to do self-sampling. For example, there are many, many different self-sampling kits. There are complicated brushes to umbrellas to vaginal lavages. So we use something very simple like this. And we have learned, and I shared this with Angela yesterday, as a clinician or doctor, we educate women, look, you put this in your vagina, so there are 3 orifices, put this in the one where the baby comes out. And they turn back to ask us, are there really 3? We only know of 2. So even our assumption that women understand their anatomy, we need to question ourselves before we teach them. And all the pictures that we have on self-sampling, you see it drawn with a straight vagina and the uterus tilted this way. In real life, the vagina is really horizontal. So if we don't appreciate that and teach that correctly, then they will have pain. And that's where you get the spotting in a postmenopausal woman. So we've learned that from experience. And with our yield in non-pregnant women, we are getting invalid rates of about 1 to 2%. 1 to 2%. And we've recently piloted self-sampling in a pregnancy population from 15 weeks up to the point they deliver. It's about 5% invalid rates, which is really, really quite acceptable for a pregnant population. But the women are starting to tell us things that, for example, doctor, perhaps self-sampling is not the best way to go in women who are pregnant. So they are telling us that themselves. So we're learning, keeping our ears on the ground, how to improve our education, our drawings, our materials that are not written. But our experience has been positive, and in a predominantly Muslim culture, there hasn't been any issues of taboo of doing a self-sampling except during fasting month and around their time of period.
So let me pick up on two things you said. Now, assuming there's no more questions. So one, you talked about getting women to screen for, essentially screening is looking for a cancer. So in many of the contexts, that including my own country, looking for a cancer is not something you go to do. How have you gotten women in your context to agree to screening, essentially looking for a problem that may or may not exist? And my second question is, you talked about pap smears. So HPV testing is a paradigm shift away from conventional cytology, away from VIA. There's been a lot of investment in that infrastructure. How did you get that transition to happen in Malaysia?
So that question is going to require half an hour because there are two questions there. There are two questions. The first one is fear and taboo. Now that's going to be very critical to address depending on which community you go to. Because for many women, when they hear HPV, it's just one letter difference from HIV. And if you package it up with a HIV screening program, that's where the stigma and the fear creeps in. So we have learned not to use the word cancer. In fact, when we first started the program, we called it a cervical screening program. We still use the word cervical screening. We don't use the word cervical cancer screening. And recently, I've started conversations with lots of community leaders that perhaps HPV may not even need to be in the whole discussion for the original screening. Not for all populations. Of course, we have to make them well informed. But it is a screening test that will prevent them from having cancer. And the cervix is associated with childbirth and their the ability to reproduce. So we call it a screening test that, if appropriate, that prevents cancer for future or looks for a problem which can be dealt with in an earlier stage rather than later. The word cancer is quite scary for lots of people from the lower income setting because it really is just purely associated with financial toxicity. They will not be able to pay for it. So if I go for a test, you find this, I will lose my life, I will lose all my resources. So what we do in the messaging is that we are detecting something early on whereby we can offer treatment, and Program Rose will say that we will cover that treatment and we will treat it without cost incurred to you. How we do that in the local setting is we only use colposcopists or the doctors from the Ministry of Health hospitals. Now, I can't produce Program Rose in another country because it may be that women have to pay for their cancer care. But where I am, in Malaysia, the Ministry of Health hospitals provide care, basic care for women. So I'm not going to put them in a situation where I diagnose something, but I cannot look after them after that. So that's sort of geographically specific, right? So coming to any more questions on that before I move on to Angela's second question? I think you need to reassure them that you won't really, clear their bank accounts if something's wrong. We can do something about it. That's extremely, extremely important in the conversations that take place before you reveal the results. So we actually spent a lot of time with the women saying that what the 3 results will mean: invalid, negative, and positive. So that information is given to the women before they undertake the test. So pap smear and VIA. So many of you will know pap smears have been the method of choice for a long time for women to have cervical screening. That requires women to lie down, have a speculum in examination, and for cells to be brushed off from the cervix. Now, the test works very, very well in a high income setting because the women will have it done regularly as their life course. No fear, nothing at all. Every 1 to 3 years, they get a letter from their GP, they go, no issues. But for women where there's no infrastructure to do pap smears, they might perhaps get one at the postnatal check. And if they're divorced or separated, they think, okay, I don't need a pap smear anymore, so they don't have a pap smear done. So where there's no infrastructure for reminders, pap smears do not work because it's only 50% sensitive, equivalent to flipping a coin. So HPV test now is a whole paradigm shift, really, from telling someone I don't need to examine you that way, to take cells, to send it to the lab, to something as simple as a swab. Now, when you have such a huge paradigm shift, the doctors are not ready for this. The patients are not ready for this. And so it takes time. We all know, with any medical innovation, they say that the average time it gets to usage, right, it's 7 years. So it's going to take a lot of effort. The science has proven that HPV test is good, but the doctors like myself still need some convincing to move and to move on from that. So the other way, because we know pap smears are not accessible to many low-income setting, the next development was VIA, visual inspection. Simple thing where you put in a speculum, you apply some light vinegar, acetic acid, and you look at the changes of the pattern of the cervix. And that's been done in many countries where there are no resources. Years have been put into investing in training such individuals who are not necessarily doctors to be able to do this. So you can imagine, I've spent so much money training this workforce, and now you're telling me that they are not as effective. I've put in money, I've put in time. These people have spent 5 years learning how to do this. Now you're saying that women just need to use a swab, you do a PCR test. So there is that barrier, that resistance to change, because it means that there's some investment loss. On a personal level, when you make some investment, when you have to say, oh, this is not good, and you have to forget it, it's painful. So when governments have invested in that, and now we're saying that, look, there's something better in the horizon, or it's here now, letting go can be a bigger barrier than adopting new technology.
There are a couple of questions.
I actually have a question of my own before, and I've got the mic, which is, I wonder, the amazing work that you're doing to get the screening to these women, how is that enabling, in a more big picture, gender equity in health? I wonder if you could zoom out just a little bit and talk about why this is so important at a sort of society level.
Okay, so not just self-sampling for HPV tests, we talk about the bigger picture of self-care. Self-care is something that we really need to push for. And I've always said this, if Program Rose is an example that can work in Malaysia or other parts in the country, it's not just a demonstration that it will work for cervical cancer, it should work for other NCDs, because you're mobilizing communities and non-healthcare professionals to undertake the big burden of screening, and you're making it available in places where individuals do not do not usually access healthcare. So it is a major part of equity because you're bringing it to areas where people don't access healthcare. So beyond cervical screening, I see this as a bigger picture of self-care, of communities taking on responsibilities. But the important thing about that is they need to be supported by proper healthcare professionals. Don't let them loose and say, okay, you go do your self-screening, your contraception, your self-HIV test, but not provide them with support. So that's going to be very critical and the responsible thing for us to do.
Thank you so much. And it's Milka de Lucini from Unity.
Hi.
I'm glad we are again talking about this. No, I'm always amazed when you speak about the program. And I think also the last thing that you spoke about is that, you know, there are countries where the switch would be from pap smear to self-collection. There will be countries, and we've seen a lot across Africa, where there will be from nothing onto self-collection. And I've been in hospitals where there would be these queues of women that for hours are waiting for the nurse to actually
Correct.
look at them and do the visual inspection in order to collect. So definitely self-collection is transformational. I'm thinking about if you can unpack a little bit something that you mentioned, around 70% of women not coming back. And, you know, it's always a trade-off on how much you want to stress the system to do that same day visit, check, treatment, versus organize it so that you can actually, you know, maybe prioritize other tests if you're talking about the laboratory. So what are some of the strategies you deployed in Rose Foundation to overcome that kind of huge?
So I can say this because in Malaysia, 78% of our population is in the urban population. It's very important to get that into context, and we have more mobile phones and SIM cards sold than there are the population themselves. So Program Rose really works on the basis that we have the ability to contact the patient and to communicate with them after they leave an event or the facility. So when we have a woman coming to us first on the first visit, they sign on when they get the SMS, they sign on to two things. One is for us to be able to communicate with them again, and secondly is for us to release the information to the primary healthcare provider should they need follow-up. That's part of our privacy data and managing all that. And to ensure that we get the right phone number and the right person, we do something like what banks do, you know, send them a tag code at the point of meeting. And with that code, they will then get back to us and say, yes, we agree to all that. Second thing is, we used to use SMS. But with a lower income population, we realized they do something called porting. So they change their SIM cards when they run out of units, and because if they don't pay for the pay after a week or two, that number disappears and they buy a new SIM card. But with WhatsApp, they keep that for a long, long time. So WhatsApp is not dependent on their phone number. And that's what we have learned. We started off with SMS, and after about 2-3 weeks, we can't contact, it says this number that you have used is no longer available. But with WhatsApp, that's now enabled us to contact the women a lot more. And I can tell you that based on our experience, 40% of women do not get linked to care initially because they either have childcare issues, they have logistics issues, or they don't have money to pay for transport, or they're having their period. So once they miss that original appointment, they don't have any access of coming back. But at Rose Foundation, we are able to follow. So we have a type protocol. Do you call us with a positive result? Do you return the call within 48 hours? If not, we will make the first call. So up to 3 phone calls, and the sort of registry allows us to track that and audit that. And if all fails, we even have their, not to say next of kin, they always give us a secondary contact. So even that we realize we shouldn't be using the word next of kin because they often may not want to let their partners know. It might be their best friend. So a simple thing like wording of, if we can't contact you, who do we contact? And it's not necessarily their partners. So these are lessons we've learned on the ground, and that is why we've been able to follow up 90% of the women. But that's a conversation I'd like to have another time, because effort to put in to get that 90% is hard work. It really is hard work. Number of phone calls, next of kin. Just so scalability is something we need to think about, how to achieve that 90% in a low income setting.
There was one more question there.
If you shout, I think we can listen.
Hi. Let's think about the molecular testing for a while.
Okay.
There are many types of HPV, high risk, low risk, right? For example, in China, usually they do the test, it's at least maybe 20 subtypes or even 30. But let's think about the cost, maybe especially think about the decentralization. Is it really need to do that many? Or we have a minimum panel of HPV subtypes. So you think it's practical, it's cost effective, and it's have a greater coverage.
It's not only practical, it's necessary that we stick to the 14 high-risk types.
14.
Now, yeah. The Asian mentality, the more the better. So I've seen, I've seen HPV tests coming back with 35 subtypes, 36 low risk, 35 high risk, and women then coming and showing me results. Because being a PCR test, there's lots of homemade kits. I can even design my own PCR test. And that's the danger. We talked about the regulation. I go to Shopee, Lazada, or these online shopping platforms. I can buy an HPV test now for $1. $1, I can buy these tests. But what do the results mean? And how, the stress that it causes with a positive result. So we need to get out and we need to regulate that more is not merrier. More is stress generating. And I mentioned that doctors are already not too comfortable moving on to HPV testing. And you bring into the field the confusion of multiple types, 30 types of HPV. Try get a gynecologist to explain that result to an individual without causing her to have a hysterectomy the next day. So I've seen so many of those women, and it really breaks my heart. They come with a test that's not been approved. They really have been told that there's a risk of cancer, but my doctor won't do anything yet. Will you remove my womb for me? So when we talk about HPV tests, we need to work better to make sure that only tests that have been approved for population screening are used. We're not looking for the obscure, because don't forget there are 200 different types of HPV. So let's not look for 50. We only need to look for those that are high risk and using a validated platform. So I speak to doctors. Many of my colleagues don't know what validated is. They say, we use this for research, but the HPV test for research setting is very different from the ones we use for community screening to get a meaningful result.
Hello, thank you so much for this very important conversation. My name is Claire Guaichore, representing the Exemplars in Public Health Global Health Program at Gates Ventures. So you started to talk about how Malaysia is a unique case where you have the financing for those that test positive. If you were trying to help other countries learn from some of the things that may be more generalizable to different contexts, you talked about longitudinal sustainable communication. What are maybe 2 or 3 other factors you would say if a country wanted to try to adopt some of this work? what are some of those key lessons you've learned that could help other countries do this work?
Thank you very much. I think it's engagement with healthcare professionals and engagement with women themselves. In my experience now talking to lots of different stakeholders, I think one of the biggest barrier are gynecologists themselves. and I think we are quite a stubborn lot, and we come out from the same sort of mold in medical school. And so many of us are taught, and our teachers and supervisors still believe that pap smears are the way to go. And I think we need to engage with professional societies to start saying, look, it's okay to give up your pap. Let's move on to HPV testing, because they're unfamiliar with it, and work out how to educate the healthcare professionals on 5 simple facts on HPV testing. Then the other thing then is to then learning from the HIV experience on advocacy and the demand from the women themselves down up, and using media that we may not be that good in, TikTok, using social media in simple language, not FAQs that are 3 pages long. We need to learn how to get the message across in a 30-second TikTok. You don't need your pap smears, go for this. 2 tests in a lifetime. So various ways to communicate effectively, short messages, not sciencey. And I think those materials can be shared across globally.
Give up your pap sounds like something that should be on a t-shirt. So again, zooming out and following up on a question Sarah Jane asked, one of the things you mentioned yesterday over dinner is that you have learned that gender equality when it comes to self-testing means different things to different people, and the words you used were, it humbled you to realize that gender equality means different things. Could you talk a bit about it?
So when we talk about empowerment, when we first started with Program Rose, it was about empowering the women. One of the politicians came up to me and just said, you better have a look and see whether their husbands will allow it. And in my head, I retaliated. All the foul language was in my head, And I said, you're not empowering women. How can you ask her husband to give her permission to do a screening test? But with time, I realized that some women do find that an area of comfort and security, and they have seen or they have lived a life where the husbands do genuinely look after their well-being. And so I've had women come in, do you think I can take this swab and my husband can do it for me? Is it okay if I go back and ask for permission? And I've heard this from the women themselves. So that's why I told Angela it was humbling for me, because I had my own idea of what women empowerment means. And I've had to learn that not every woman wants to do something themselves, for themselves, as seen as an independence. That's what I've learned.
And where are the men in this whole HPV self-collection? Picking up on what you're saying, what's the role of the men? Where are they?
So I give you a story. One of my colleagues is a male gynecologist. He says, let me go to the mosque. Let me talk to the men and tell them to get their wives out the following week. So we've had quite a few male champions. We've had male MPs. We've had males talking to males, and please protect your wife and make sure they come out to have their screening test. We often go into programs where the men and the women, and together with their children as well, so it becomes more of a family affair. So I can tell you we've had community programs where we've called it a family health day. So children get dental checks, and they have their nutritional status measured. Men have their blood pressure and their diabetes, their sugars checked, women have the same done and also have a self-sampling done for cervical screening. So it's a whole idea where you keep the family healthy, and so the men are quite involved in that. So the men will be having their test done, then we will ask them, you know, or the doctors will ask them, have your wife had the other test done? So making sure men promote cervical screening as well.
And so, I mean, we all know hindsight is 2020. So, and in many of the high burden countries that we're working in, if the 70% goal is the rope at the end of the race, many of the countries are not even on the race, they are still in the gallery. If you could go back to the beginning and speak to you at the beginning, what would you tell yourself? What would you do differently? What would you stick to?
I would accelerate the use of expertise outside the medical field a bit more. So when we talk about scalability, using experiences of project managers in telcos, banking, even the oil and gas industry, where they are very good at project management to look at different aspects of how to scale. That is someone I would use from the very beginning. I would also speak to lawyers at the very start to talk about our personal protection of data so that I don't have to learn that piecemeal. And of course, having the seed funding to be able to do that initially, because Program Rose started with crowdfunding. It's a few Malaysians coming together, believing that they can make a change. So we started off the pilot program. Honestly, the pilot program was about $30,000 US, and individuals giving of their time. So we had computer programmers who were retired who says, "I'll help you do this." We had our project managers and accountants coming in and says, "We'll help you do that." But if I have the insight, I want to do it more efficiently by better qualified people at an earlier stage, besides just working around the individuals with medical training. That is something I want to go back and improve. But one thing that, of course, COVID really helped us was the conversations with women. Swabs, PCR now, it's really a walk in the park now compared to back in 2018.
And something else you said earlier to me was you're not, the numbers you're trying to reach, you're not trying to increase the number of women. Program Rose is screening because you do not want to take the role of the government. So how are you working with the government, and how is that?
So Rose Foundation really works on many aspects to help the country achieve elimination in an accelerated way. As a foundation, we don't look at numbers of women screened. So our target is not, okay, it's 20,000 this year, make it 300,000, 1 million, and that's not what I foresee the role of the foundation. But the role is to give critical aspects of filling the gaps. So for example, one of the things we realize about reimbursement is that insurance companies still view HPV as a sexually transmitted disease, and so private doctors do not do HPV testing because the insurers will not reimburse the doctors, because once it's STD, you're on your own. So the doctors will therefore do pap smears because it's a cancer screening, and so the follow-up care will be covered by insurance. So this is where you don't just need to talk to the doctors, you need to talk to the insurance. Hey, you need to reimburse them if they take a positive step to look at their health care using an evidence-based method. And if you go around Asia, you will find that that's the practice of many insurers. They are still not paying for follow-up care if a woman is screened positive for HPV. So Rose Foundation engaged with 14 insurers in Malaysia to educate them. We also took the opportunity to educate them that people living with HIV live their long, normal lives now, because HIV in our country are not people living with HIV are not eligible for mortgage or loans. Right? Based on old understanding of the disease. So we have multiple roles. So you see, you look at the shock on your faces, right? But you think it's a given in many of your countries. But in our countries, they still don't get the financial help that someone who doesn't live with HIV have. So they can't get insurance, they can't get loans. It's terrible. And so Rose Foundation works on those gaps. How do we deal with the financial sector? How do we educate them? We look at technical aspects, we look at policy, we look at creation of materials. So for example, one of the early experiences that we had, and Ministry of Health was trying to move to HPV testing, and so one of the educational banners to get women in to screen. And of course they had, they took it from the internet. I don't know where they took it from. It says, do you have multiple sexual partners? Do you smoke? Are you on the pill? If you have these risk factors, please come for HPV testing. You may cringe, but many still do that. They still link all this behavior to the risk of cervical screening. So Rose then engaged with their educators and said, no, this is stigmatizing. This will increase discrimination. Can we change that? And so they have. So these are the roles we want to play, not a numbers game, but changing the narrative, changing the education, changing the landscape of how doctors and financial institutions behave.
Sadly, we are at time, but we are around for the tea break, I presume.
Yeah, absolutely. It's a shame to cut that conversation short, but we've got a short break now. If anyone's got any more questions.